Professor Ebeling, welcome to the Physical Performance Show.
It's really nice to be here, Brad. Thanks for inviting me.
You have been on the wish list for quite some time since Professor Belinda Beck here on the Gold Coast, Australia, introduced me to you or informed me of your expertise in the area of bone and in particular osteoporosis, and to capture you with a man who is so full with day-to-day activities is quite the thrill and honour. Your academic and clinical work is absolutely extensive and extraordinary. What took you into the area of interested in bone health and particularly osteoporosis, Professor Ebeling?
Yeah, well, that's a great question. It's one I tell my medical students about, because when you're a medical student, you really don't know what you want to do in terms of a career. And I told them it's really just making the most of the opportunities that present themselves. So when I was doing my medical training, I was lucky enough to be at a hospital which had a very strong endocrinology unit. So a lot of the doctors working in that unit have subsequently, like me, become professors of medicine and heads of academic departments of medicine. So I was lucky enough to see how good endocrinology was from these strong leaders. And I decided to do endocrinology because it's difficult to make the diagnoses sometimes, but if you do, they're fairly transformative in terms of improving a patient's life. And a lot of the conditions are treatable. So, and I also like the long-term management of patients with conditions, so you get to know them over the long term. So I guess that's the reason I chose endocrinology. And then I decided to do research, and I was lucky enough to be on a team that discovered a new hormone, parathyroid hormone-related protein. So that was my doctorate. And then I went across to America to work there for 3 years at the Mayo Clinic, where I started doing clinical research in osteoporosis. And again, I had a really great mentor there in Larry Riggs. And I spent 3 years there, published a lot of papers, and then came back to Melbourne and have really continued in that vein since then, with a couple of other interludes overseas in Oxford and New York. So here I am today.
And recently, Professor Ebeling, you were appointed the first non-American, I believe, and you may have to help me here, Peter, we'll edit this in. The role you just took was...
Yeah, so I've become the first non-North American president of the American Society of Bone and Mineral Research. So that's a huge honor, and it's been a busy role since I took it on about 5 weeks ago.
Yeah, and a fit-in one as the first outside of America person to hold that role, and so fit in for all the contributions you've made. As per your bio, over 450 peer-reviewed publications, just prolific and extraordinary. Osteoporosis, if we focus there, Professor Ebeling, how would you define it, and why is awareness of it so important in society at large, but also in amongst athletes?
I think osteoporosis is a bit of a confusing word because it's a bit like another word, osteoarthritis. And I know patients get the two confused. So really, it only means porous bones. That's what it means, whereas osteoarthritis refers to joint disease you get with aging. So I think it's not a great word, and it's a hard one to explain to the lay community. And that's why we've renamed Osteoporosis Australia Healthy Bones Australia, to get the idea away from a disease state, but maintenance of good bone health throughout life. But osteoporosis occurs when you break your bone after trauma that a normal person wouldn't break their bone. So it's a product of having reduced bone density and a reduction in bone strength that leads to that broken bone. So the thing is, you don't know you've got it until you have a broken bone, or if you get a diagnostic test. And the diagnostic test we use is bone density, using a technique we call dual energy X-ray absorptiometry, or DEXA.
Certainly, and the renaming of Osteoporosis Australia to Healthy Bones Australia is, I think, a very smart move. And you shared that phrase there. It's about maintenance of good bone health across the lifespan. We've featured this on prior episodes, but I don't think it can be overstated enough. I guess the key is people can do things to optimize their bone health across the lifespan, correct?
They definitely can. And really, it starts in childhood, and probably exercise is most important just before you go through puberty and around the time of puberty, because the bones are still growing then, and it's what we call modeling. And that's where the influence of exercise is tremendous. And it's the weight-bearing type of exercise that's important then. So playing, active sports like tennis or football, basketball, all of those things would really help children optimize what we call their peak bone mass. So if we increase their peak bone mass by 10 or 15%, which is achievable with exercise then, that can reduce their likelihood of getting osteoporosis when they get older in their 50s or 60s or 70s.
And the incidence or prevalence of osteoporosis amongst the population is what, Professor Ebeling?
So we think just over 1.3 million Australians have osteoporosis, or that would be defined as having a T-score, which is a measure of bone density that's comparing your bone density with a young adult at the age of 30. So if that T-score is minus 2.5 or less, we call that osteoporosis if you use the bone density test to diagnose it. So we think 1.3 million Australians have osteoporosis, but another 5 million or so have low bone density or poor bone health. So what we want to do is to try and capture those Australians and to reinforce what they can do to make their bones healthier.
So 5 million Australians with poor bone health. And is that defined as the osteopenia, Professor Ebeling?
It is, yeah. So all osteopenia means is low bone density or not enough bone. And that's defined as, again, looking at those T-scores, it's a T-score between -1 and -2.5. Now, a T-score is what we call in mathematical terms a standard deviation. So that means statistically your bone density is between 1 and 2.5 standard deviations below the young adult mean.
And demographically, how's this spread? So if we focus on the 5 million Australians with poor bone health or osteopenia, how's it spread? Bias towards certain age groups or age brackets?
Yeah, normally osteoporosis affects postmenopausal women, so women above the age of 50, and older men, typically above the age of 60. So these groups are more at risk of getting low bone density. And if we look at the broken bones that occur due to osteoporosis, 2/3 of them are in women and 1/3 in men. So a lot of people don't realize that men can get low bone density and osteoporosis as well. But it's definitely a possibility, particularly men used to smoke quite a bit and drink heavily. And both of those lifestyle factors are important and can cause low bone density, but they're also genetic factors. So if you've got a family history of broken bones, that can predispose you to having osteoporosis, whether or not you're male or female.
So the role of genetics, we can't escape it. I have read that circa 70% of bone health could be genetic. What would be your guesstimate there, Professor Ebeling?
Yeah, it depends on which group we're looking at, but certainly in men and younger people, genetic factors may be relatively more important. And I think it's this combination of genetic predisposition and lifestyle factors that are really important. Unfortunately, you can't choose your parents. That hasn't been identified on how to do that yet. So what we're left with doing is having a healthy lifestyle approach, and that can mitigate some of your genetic risk by doing that. And what I mean there is by having an adequate calcium intake, so having at least 3 serves of calcium-containing foods a day, making sure your vitamin D is normal, and the normal level is about 50 nanomoles per litre on a blood test. So we'd like it to be above that. And also having regular weight-bearing exercise and reducing alcohol intake to the recommended levels and stopping smoking. So by doing these things, you can sort of improve or maintain your bone mass over life.
Professor Ebeling, you shared that people are often surprised that males develop poor bone health or osteoporosis. There is certainly that that belief, I think, that pervades a lot of society's views that this is just a condition of the mature in age, and also females. Sub 50-year-olds or sub menopause or menopause. I work in a very biased sample of athletes who are runners often and endurance athletes. And if you go back to the definition that you shared, that people are often only aware that they have poor bone health when something goes wrong, whether that's a fracture or perhaps a series of bone stress injuries, stress reactions, stress fractures, etc. Any insights you've gleaned from your clinical practice over the years with sub 50-year-olds who detect that they have osteoporosis or osteopenia?
Yes, I think this is a really important group, and we've just written a couple of publications reviewing this. One is called Secondary Osteoporosis and just been published online in Endocrine Reviews. And then the other one is about osteoporosis in young adults and the dilemmas in diagnosis and treatment. And I think that's hopefully going to come out in JBMR Plus very soon. So this is a really important group. And I think more often than not, we don't use the T-score to diagnose low bone mass under the age of 50. What we tend to use is a Z-score. Now, the Z-score is comparing your bone density with your age and sex-matched peers who are normal. So we tend to say that if the Z-score is less than -2, so that's 2 standard deviations lower than your age and sex-matched peers, that you have low bone density. Now, we also say you would have osteoporosis if you have a chronic condition associated that might cause low bone density, or if you've had a broken bone on minor trauma. So that could include a stress fracture. Now, obviously, I've seen a lot of athletes, and some of them have low bone density, and they get an increased likelihood of having stress fractures or stress reactions, like you mentioned. And certainly I've seen a lot of professional cyclists on the European Tour, and also footballers with these stress fractures. So it comes down to a couple of things. One, you can't exercise too much because your pituitary and hypothalamus are very sensitive to over-exercise. And irrespective of whether you're a woman or a man, the intensity of the exercise might increase sort of your endorphin and cortisol levels, and that can shut off the hypothalamus and pituitary to reduce the production of sex hormones. So that would be estrogen in a woman or testosterone in a man. So we see this, and in a woman, they would have lack of periods or amenorrhea. And we call that term athletic amenorrhea for that reason. And in men, there would be a low testosterone level, which would be manifest as low sex drive and maybe a reduction in body hair. So these things can occur with too much exercise. So the amount of training you do is really a balancing act. And the other thing, apart from that hormonal aspect, is that bone is like it's a structure that's made up of spongy bone on the middle and compact bone on the outside. And it's, subject to the force of recurrent loading. So if you're loading the bone too much with the exercise, it'll just get a stress fracture related to the the stress on the bone that's occurring. So I think that's really important to recognize that you can't, and that's why sometimes you have to moderate the amount of training you're doing. Now, these things are exacerbated if you have a low body mass index. So if your body mass index is below 19, which is the recommended level, that can make all of these things worse as well. So maybe that's why we're seeing high performance athletes get these stress injuries, and it's just addressing those things. One of the ways to try and prevent it is boosting your calcium intake. That seems to be a good approach for reducing the propensity to getting these stress reactions.
And I feel, thank you for sharing there, Professor Ebeling. So it's multifactorial in the sub 50-year-old. Need to consider hormonal aspects, working with an endocrinologist like yourself who understands bone and exercise, and then also looking at training patterns and loads, considering BMI, which is a subset, I guess, of fueling that amount of activity. And it's certainly well pervasive in endurance sports, low energy availability or relative energy deficiency in sport, which then can obviously heighten the risk of these bone injuries. Professor Ebeling, I've been through this personally. I've shared this on this program in the past, my own diagnosis with low bone density, which came quite as a shock to me as a 36-year-old that's never smoked a cigarette in his life or drinks any alcohol. And I see that quite routinely with patients, often in the endurance sports world. They have a sports-related injury, and then through the assessment of that, they pick up low bone density. And I feel like there's almost a grieving period where they come to grips with that, where they feel like they were bulletproof, fit young adults, and then all of a sudden they're being told that they've got a condition that most people associate with elderly age or the maturing age. Any insights you'd share around that, or comfort or reassurances? You've certainly, and you're my endocrinologist, and you have brought me great reassurance, Professor Ebeling. But what would you say to that group of people that do realize they've got low bone density and they're only young in years?
Yeah, well, the good thing about it is you're never too old to do something about low bone density, and it can be reversed by doing some of the things we've talked about, like making sure you have a good calorie intake, but also a good protein intake. We sort of neglect protein, but the quality of the protein is also important. There have been some recent studies showing that veganism has been associated with an increased risk of osteoporosis, and it's thought perhaps that might be due to low quality protein, because you have to understand that the bone is also composed of protein as well as calcium and phosphorus. So protein intake is important as well. And avoiding the low body mass index and making sure your sex hormone levels are normal, and avoiding those lifestyle factors. So if you do all of those things and maybe moderate your training schedule and reduce the intensity of training, the bone density will bounce back. And that's what I've seen, in particular with these young professional cyclists who've had to actually retire from the European circuit, that once they do that and adopt a good lifestyle, their bone density really goes up quite a lot.
How much, it's always going to be, thank you for sharing there, Professor Ebeling. It's always going to be individual, of course. There's responders and non-responders on a continuum, but how much bounce back is possible?
So I think you can see improvements of 5 or 10% using those approaches. And certainly in young people, we try to avoid any pharmacological treatment as much as we can. But there are some cases where they have a lot of fractures that we might give them a short course of treatment, and that will also help the bone density go up.
And that might include what sort of pharmacological agents, Professor Ebeling?
Yeah, so when we're thinking about stress injuries in athletes, there is sort of limited data, and there have been studies showing that the oral bisphosphonates, which are anti-resorptive agents, they're taken as a weekly tablet. They can improve bone density in this situation, but we don't have any data showing that they reduce further stress fractures. And I know that in professional sports, there's another medication that's been used to treat osteoporosis and treat severe osteoporosis. And it's also been shown in a couple of randomized controlled trials to improve the healing of wrist fractures and also pelvic fractures in older women. So that is a daily injection which actually builds new bone called teriparatide. And I know that that is used by some professional athletes to sort of increase the rate of healing of these stress fractures, but we don't know for sure that it does. It's just based on these other studies with complete fractures. We haven't got any trials showing that it actually improves the healing of stress fractures, unfortunately.
And is there any potential downside or long-term impact of these pharmacological agents for patients or people in the younger demographics?
No, I think not. I think, they wouldn't be used for long periods of time. With the oral bisphosphonates, the only side effects in the short term really are indigestion and a loose bowel habit, maybe the day after you take them. In prolonged treatment, there are rarer side effects such as osteonecrosis of the jaw or another type of fracture we call atypical femur fractures, but these are usually associated with long-term use, for up to 10 years or so, and aren't seen in shorter periods of time and are very uncommon. With the teriparatide, there was a concern that it shouldn't be used in young people, and it's contraindicated in adolescents. But in young adults, it's been used to treat osteoporosis in trials, and it's been useful in improving bone density. And it seems to be very safe. There was a concern that it caused osteogenic sarcoma in rats. So if you're a rat, it's not a good drug to take. But there's been a long registry study going for 15 years, and of over 1 or 2 million people that took the drug over that time, there were only 2 cases of bone cancer, which would be expected. And for that reason, in the United States, this drug used to be limited to 2 years of treatment over a lifetime, but people can now take it for as long as they need to.
And so teriparatide for Teo, how may that be administered? And obviously this is not medical advice, just general information. It's not specific to someone's circumstance, but what would administration potentially look like?
Yeah, so with teriparatide, when we use it for treating severe osteoporosis, it's given as a daily injection from a pen. So patients have to learn how to give the injection themselves. It can be associated with some side effects such as headache, giddiness, or dizziness and nausea. And some people, for that reason, have to take it in the evenings before they go to bed to minimize those side effects. But most people learn how to use the pen device pretty readily. But having said that, there's probably quite a large proportion that don't want to have the medication because of the nature of the administration as an injection.
And is that ongoing indefinitely, or is there periods on and off?
In Australia, we talk about Australia, it's limited to 2 years per lifetime that you can take teriparatide. Whether or not that'll change in Australia like it has in the United States, I'm not sure.
So 2 years of dosage per lifetime, so that can be broken up in intervals.
Yeah, so in the treating severe osteoporosis, we usually use it continuously for 2 years. Because then what we do is consolidate the benefits. We get all this new bone that's formed, but some of it doesn't have a lot of calcium. So then if you add, because it's new bone, if you add an anti-resorptive agent like the drugs we were talking about, a bisphosphonate or another drug called denosumab, then the bone density will go up further. So the appropriate sequence, the sort of Rolls-Royce treatment for osteoporosis would be to give one of these drugs that increases bone formation. We've got 2 at the moment, and then giving an anti-resorptive drug after that. But at the moment, for osteoporosis, the reimbursement is such that we have to use these bone building drugs as second-line treatment when the less expensive anti-resorptive drugs stop working and patients have more broken bones.
And of course, it's going to be individualized always, and hence why anyone working through low bone density does need a sound endocrinologist, someone like Professor Ebeling in their corner. And I was warned, Professor Ebeling, that not all endocrinologists would necessarily understand the sub 50-year-old or the exercising one. And I sought some local assistance early through EASE, and the advice was very different to the advice that, say, you've shared with me. And so I think, like most medical conditions, you do need to choose your practitioners wisely, correct?
Yeah, I think you have the opportunity of not going back to see a specialist if you sort of, for some reason, aren't satisfied with them, and to choose another one, or ask your GP to select another one to refer you to. So that's quite fine, really. Yeah.
And certainly not throwing any colleagues under the bus, of course, but it's just important to make sure you're comfortable, I guess, with the specialists you are working with. Bone turnover markers, Professor Ebeling, what's available there? The diagnosis can be made via DEXA, like you shared earlier, but bone turnover markers and the role of blood work. Can you share around that?
Yeah, so that's a good question, Brad. And bone turnover markers. So how we get osteoporosis is there are a number of bone cells and there's one that resorbs bone or breaks down bone, and that's called an osteoclast. And the other type of important bone cell is the one that builds new bone, and that's called an osteoblast. So generally when osteoporosis occurs, there's an imbalance between the activity of the bone breaking down cell and the bone forming cell. So what we see most commonly is the bone breaking down cell is working overtime, and you're losing bone. So if that's the case, we can then measure some of the products from the bone that's being broken down in the blood. And what we measure is a thing called the CTX, or C-tylopeptide, which is a part of the collagen molecule that's broken down or chewed up by the osteoclast and then appears in the blood. So we can measure that in a morning specimen, but it's really important that you don't eat before you have the blood test, because if you eat, the marker can go down. And it's important to have it in the morning because these markers change during the day. So that's the best time to have it. And the other type of marker is what we call a bone formation marker. And that is, again, it's cleaved off when the collagen is actually made and comes out in the blood, and we can measure that as well. And that's called a P1NP level. So we can measure that in the morning as well to see how much bone formation there is. So how we generally use these bone turnover markers is first initially to see if there's any imbalance. So you might have a high CTX and a low P1NP, and that's sort of a bad scenario. And then we'd recommend, if your bone density was low, that you have an anti-resorptive drug. Then if we're putting you on one of these medications, we can measure the response of these bone turnover markers after a few months. And if you're taking a tablet, we want to make sure it's being absorbed and that you're taking it properly. So I usually get people back a few months after being on one of those oral bisphosphonate drugs we talked about to make sure it's working. So that's one way to use it. And then similarly, if we're using one of the bone building drugs, then I would measure the bone formation marker, the P1NP level, a few months after people start on a bone building drug to make sure that that's gone up. And that usually goes up, either doubles or goes up 3 times when people are on these bone building drugs. Whereas the other bone resorption marker, we put people on the other types of drugs, that goes down by about 70% or so.
Fascinating things. The 24-hour urine test, Professor Ebeling, I've been through that one myself. What does that involve, and what can be gleaned from that?
Yeah, so again, one of the conditions that can cause osteoporosis in young people and in older people is that there's a leak of calcium from the kidney. So the way we can find out if that's occurring is to collect every drop of urine over 24 hours and measure how much calcium your body's churning out over 24 hours. Now, the good thing about that is we can treat that leakage by giving you a fluid tablet, just by a simple, what we call thiazide diuretic, going on half a tablet or one tablet of that every day. That will stop the calcium leak in the urine, and the bone density will probably go up a little bit as well.
So once again, follow the guidance of your specialist or endocrinologist and go through the required process. Something that I learned going through the process, Professor Ebeling, was, I guess, the sensitivity of bone. At one stage, my bone resorption markers from memory were a little low, and I'd just come off the back of, were a little high, I should say, off a recent bone stress injury. And you commented that, well, that's likely reflective of that. So this is very sensitive machinery.
Yeah, it is, because when we break a bone, they're really in hyperdrive, if you like, all these bone cells, both the bone resorbing cells and the bone forming cells. So what they're doing is getting rid of the broken bone and building new bone. And that means that they're usually very high after one of these stress fractures or fractures, that we find that some of the bone formation markers can remain elevated for about a year after a broken bone. So we have to be aware of that.
1 year, that's extraordinary. Professor Ebeling, there's a term that I know yourself and your colleagues, research colleagues, are researching. I think there's a trial going at the moment called osteosarcopenia. And it's the first time I've seen that word. Sarcopenia is quite widely recognized in the healthcare circles. But can you elaborate on this term, osteosarcopenia, and why it matters?
Yeah, so I think and really Gustavo Duque, who's at the University of Melbourne here in Melbourne, has been the one looking at this. And this is just to determine whether people who have got the combination of low bone density or osteoporosis together with low muscle mass sarcopenia, as a group, they tend to have a greater risk of getting broken bones than people without the combination of sarcopenia. So again, it gets back to some of the nutritional things we were talking about to try and prevent people getting muscle wasting as they age. So it's, again, I think that emphasizes the need for adequate nutrition and protein and calcium, but also regular weight-bearing exercise as we age. And I think, as people get older, they don't exercise as much. So I think that's a real difficulty of how we get people in their 60s and 70s continuing to exercise in a regular way, because once you stop, you lose it. So if you don't use it, you lose it. So you've got to keep doing it. And how do we engage people with an exercise that they'll enjoy doing and keep doing 2 or 3 times a week in the long term? So it's a big dilemma.
And the type of exercise we know matters, and research colleague or peer, Professor Belinda Beck, her work with, say, the Onero bone program, where it's resistance training, which is often not something that those in later years would gravitate towards, but there's been some great results with resistance training on the skeleton.
Yeah, so Belinda did her study, and we did a study in Melbourne as well, led by Rob Daly in community gyms in Western Melbourne, where I was, and that was called the Osteocyte program. And it's this high-intensity progressive resistance training that's really important. And if you do that, your muscles will get stronger, but also your bones will get stronger, and the bone density will go up by a few percent depending on where you're measuring it. So I think people definitely feel better when they're doing these exercises as well. And hopefully they become more active generally as well as having the focused exercise. So yeah, it's a really important thing. And I think that works because you're being supervised, and you like to turn up to meet the other people. And that's certainly what we found with our Osteocyte program. That was a group exercise program, so small groups of 6 people, and they feel committed to come and exercise together. They build up social communications with the others in their group and feel obliged to go. So these are some strategies we can use to try and encourage people to attend exercise regularly. We can make them pay for it, and that's another way, I guess.
Yeah, whatever it takes to engender lifelong participation with activities that will help for not only just the skeleton, but also resistance training with sarcopenia or reduction in muscle mass. So key.
So the groups obviously involved in this are physiotherapists and exercise physiologists. And if a patient has osteoporosis, their GP can develop a chronic care plan, and 5 visits a year to a physiotherapist or exercise physiologist will be covered by Medicare under that chronic care plan. So that's the other thing we encourage the GPs to do.
Yeah, brilliant. On that, the cost of osteoporosis to Australia nationally, what is the impact of osteoporosis-related injuries or conditions?
Yeah, so currently the cost, Brad, is about $3.2 billion a year, and most of that cost is related to treating the fractures. Probably just over $2 million is related to treating the fractures, and then there are other costs as well. So that's why we need to do something about it, particularly as the population is aging. We don't want these costs to keep going up. In the next 10 years, that would cost us, between 35 and 40 billion unless we do something about it.
Goodness, we could pay off the COVID-related debts with that saving, right?
Yeah, well, it always goes somewhere else.
Oh, gosh.
That's hard. Yeah.
Professor Ebeling, athletes coming out of cam walkers or boots that have been deloaded to heal a bone injury, often a little bit surprised with sometimes the radiological reports around transient bone loss through deloading. Any advice or encouragement, reassurance you'd share to that group?
Yeah, certainly that occurs quite quickly, and I guess the extreme form is after paraplegia, where they lose bone very dramatically from the lower limbs and spine. And, we can preempt that by giving them some intravenous bisphosphonates. But, I think it will go quite quickly in a cam walker over, 6 weeks or so. And then the answer is to gradually reintroduce weight-bearing exercise, and hopefully you'll regain a lot of the bone that's been lost.
It's a great example of the mechanosensitivity of the skeleton. It goes, but it does come back.
It does. And there are another type of bone cell I haven't talked about is the osteocyte, and that controls the response of the skeleton to exercise. It sits in a little lake in the bone, and that's why the weight-bearing exercise is important, because it'll start bouncing around in that lake and it'll send off a signal to inhibit an inhibitor of bone formation, and that results in an increase in bone density. So that's how the mechanostat works in bone.
Gosh, and the thought that bone is just a dead inert structure in our body is couldn't be further from the truth.
Yeah, so if I was giving this interview 10 years ago, we'd both be sitting here with different skeletons, because that's how long it takes for our whole skeleton to be replaced.
10 years.
10 years.
Gosh. And 1 year for full mineralization of bone that's reforming. Is that correct?
Yes. If we think about if you went for a run today and you got a sort of a little stress fracture on one of your bones in the feet, the osteoclast would come in and sweep away that dead bone, and then the bone forming cells would lay down new bone and it would all be repaired. That whole process would take about 3 months. So that's occurring all over the skeleton. And if you look at how long it would take to replace the whole skeleton, it would be about 10 years.
Oh, gosh, fascinating. Professor Ebeling, a clinical finding or clinical radiological report that occasionally pops up is this transient bone marrow edema that seems to be associated with symptomatology or pain in that region. Anything you'd share around that? I've heard medical colleagues debate whether it's a legitimate condition or not, or whether it's just pure bone stress. Transient bone marrow edema.
I think what's happened is that we've come up with this diagnosis, and it's based on MRI findings. So once you've started doing MRIs, you've come up with this sort of diagnosis. So it's an MRI diagnosis, and we're not really sure of the clinical associations, but sometimes it can be associated with pain, and we just also wonder if it's occurring before a stress reaction occurs. You know, it might be the first thing that occurs leading to a stress reaction. So maybe it's a bit of a warning, but we're not quite sure about it. Yeah.
Could be a precursor. The role of orthobiologics in bone healing, Professor Ebeling, I guess you'd mainly see it more in the athletic populations trying to get ready for an event or a major competition, but anything you'd share around the effectiveness or otherwise of certain agents?
Which ones were you thinking about in particular?
So things like exogen units, etc. Yeah,
I don't know that there's any objective evidence that they work. I think, we've gone through a phase of thinking that vitamin K2 might be helpful. So that might be one of the things. But there was a recent study that was done in Denmark. It was just published this year, and that showed that in two groups of people, they both got calcium and vitamin D, and one of the groups got vitamin K2 and the other got placebo, and there was no difference in the bone density over a couple of years. So we don't think vitamin K2 has got a major effect. Vitamin D is probably most important in those with the lowest vitamin D level, so less than, say, 30 nanomoles per litre. But we know in particularly the institutionalized elderly that the combination of calcium and vitamin D will prevent fractures, and that's probably because a lot of them have very low vitamin D levels. So in South Australia, they give calcium and vitamin D to everybody in a hostel or nursing home there. In Queensland, probably people get outside more, and there's less, we know there's less vitamin D deficiency in the population. But in somewhere like Melbourne or Tasmania, about 50% of the population will have a low vitamin D level in winter in those states. So, yeah, vitamin D is probably an important thing still.
And the best way to correct that is sun exposure, but then there's also times where that's just not available, and therefore...
Yeah. So we don't recommend going outside of the UV indexes above 3. And if you do, to apply sunscreen, wear a hat and sunglasses, and seek shade. So the thing is, when you apply sunscreen, you don't apply it perfectly, and you can still make a little bit of vitamin D even if you do have sunscreen on. And that's been shown in a study from Sydney. So that's probably good news, yeah.
Is there a minimum amount of exposure needed to increase vitamin D levels, or it's variable depending on the sun intensity, etc.?
Yeah, so what you probably need is just a few minutes in the summer months, but in the winter months you may need, depending where you live, quite a long time in the sun at midday, like that would be half an hour or longer in Melbourne, depending on your skin pigmentation.
Professor Ebeling, you've been very generous with your time and, of course, your expertise. And every guest of the show gets issued 2 set questions. So the first is, if you could, and we'll keep this contextualized to this topic of bone health across the lifespan, if you could boil everything you've learned through your professional career to date into one single piece of advice to help listeners of this show optimize their bone health, what would that be, Professor Ebeling?
I think move it or you will lose it.
Move it or lose it, or you'll move it or you will lose it. That's brilliant and fitting. And the second set question, Professor Ebeling, is this, and every guest issues listeners with a physical challenge for the week. So what is Professor Ebeling's physical challenge going to be?
Oh, that's a really tough one. So it would be something to improve your bone health. So I think you should do high intensity progressive resistance training for at least 3 times a week. So for 20 or 30 minutes.
High intensity progressive resistance training 3 times a week for circa 20 to 30 minutes. Yep.
Yeah.
Very, very important. Professor Ebeling, you are prolific academically. You're available clinically as well. But are there any projects you'd like to flag at the moment that you might be recruiting for subject-wise with your studies, et cetera? I did the maths on this last night, Professor Ebeling, 450 peer-reviewed publications. I think it was 153 across 5 years. I worked that out to be circa 16 per month. That's extraordinary.
Well, yeah, it's, I don't know. We've got lots of PhD students and postdoctoral fellows, and they're all working very hard. It's really a team. It's just not me, obviously. I don't get a lot of sleep, though, I'd have to say. But yeah, I think what we're interested in at the moment is doing one of the first studies in Indigenous bone health. And we've been very careful in setting up consultative processes with Indigenous communities in Perth and in Melbourne. And we're trying to recruit people into that just to find out why Indigenous Australians have broken hips about 20 years younger than other Australians. So we're trying to figure out why that's the case. And then we're also interested in doing research on an unusual type of fracture that's associated with long-term bisphosphonate use, and that's in the femur. So if anybody has had one of these, what we call atypical femur fractures, we're trying to work out if there is a genetic cause or whether there's a problem with the geometry of the femur that might predispose to people getting this. So yeah, we're doing that in collaboration with universities at Oxford and in Erasmus University in the Netherlands, and also some universities in Singapore and Thailand. So it's, because it's a rare disease, we've got an international approach to that problem. So yeah, there's some of the things we're working on at the moment.
And you're available clinically via Jean Hales for Women's Health Clinic, East Melbourne.
Yeah, I'm very limited, only half a day a week.
Yeah, no, totally. And I was informed that it might be difficult to get in to see you, but I certainly have been appreciative of your guidance for my own personal health and many of my patients who have been referred your way. Professor Ebeling, I do hope you get some sleep tonight. And I should ask, though, your view on the role of sleep and skeletal health.
I think sleep is really important for all aspects of health and probably for your skeleton as well. We're not quite clear, but I think it's really important for your cardiovascular health in particular. So just 7 or 8 hours is always a good target to aim for.
Professor Ebeling, thank you for your contribution to the show.
It's a pleasure, Brad. Thanks for asking me.